Good evening, all of you. We are live. All of you, can you see me now? Am I audible? And then we'll talk about the recall of pediatrics UPSC this year. So, all of you, can you write in the chat box? Good evening, all of you. Yes, I can hear myself on my cell phone. And let's see if we have some chats here. So, what we'll do is we will be discussing all the questions which came about pediatrics in this UPSC combined medical services exam this year. So shall we start? Okay, I can see a lot of students. Yeah, thank you for Guru Purnima messages, everyone. So what we'll do is we'll straight away start with the first question, and what I'll do is I'll keep on discussing these questions with you. So this was the first pediatrics question which came in the UPSC exam. The question is, which of the following fine motor milestone will appear ahead of the others? Copying across, copying a circle, drawing a circle, and drawing across. What do you think, guys? So see, obviously, in a child's life, he will first try to, imitate drawing something. Then only he can draw it himself. Okay, that's obvious. You will first try to imitate drawing something, then you will draw yourself. Okay, so if I show you Nelson's textbook, so the Nelson's textbook has a table where it clearly says that at 3 years of life a child initially copies a cross. Okay, so a child initially copies a cross. Or what about circle, guys? So cross he copies before the circle. So 3 years he copies a circle first at 3 years of life. Then after this he is able to draw a circle. Then at around 4 years of life he will be able to copy a cross as well. Okay, and then he will be able to draw a cross. So first he copies, then he learns to draw himself. So circle पहले आता है, फिर cross and square आते हैं. Okay, so फिर cross and square उसके बाद आते हैं. Okay, all of you, cool? So this was the first question. So remember, that's obvious that once you learn to imitate a drawing, then you can make it yourself. So obviously copying पहले आता है, drawing बाद में आता है. Okay, yes, you're right. So let's take you to the next question. And especially for the UPSC exam, OP Ghai textbook is the gold standard. I will show you a lot of text from OP Ghai textbook, from the current Nelson's textbook. So it is, all the questions are taken word to word from OP Ghai textbook. So what is hypertensive emergency? Let me first ask you, what is hypertensive emergency? What is hypertensive emergency? Hypertensive emergency means that a patient has a stage 2 blood pressure. So it means basically, so if I talk about what is hypertensive emergency, so it is defined as a patient has stage 2 hypertension, so he has a very high blood pressure, plus he has symptoms. Okay, so plus he has symptoms. So he has a stage 2 blood pressure, plus he has symptoms. So what do I mean by stage 2? By stage 2 I mean that his BP is more than the 95th percentile plus 12 millimeters. So his BP is more than 95th centile plus 12 millimeters, plus he has symptoms. So what are the symptoms we talk about? Symptoms are like he has very severe headache, he has seizures. So he has seizures, headache, and most importantly left ventricular failure. So here is a child who comes to you with gallop rhythm, basal craps. He has a gallop rhythm, he has basal craps. ओके हम बच्चों की बात कर रहे हैं बाबू, देयर इज अ डॉक्टर बाबू इन द चैट बॉक्स। सो बच्चों की बात कर रहे हैं। सो इट इज मोर देन 95th centile plus 12 millimeters plus symptoms. So let me show you a from the OPGI textbook. I'll show you a typical sentence. So when you use drugs, the drug of choice is an IV infusion. So drug of choice for hypertensive emergency is an IV infusion, which is mostly in our country sodium nitroprusside or sodium nitroglycerine or nicardipine is a very good drug and now it is available in our country. We use a continuous IV infusion of nicardipine. You can also use labetalol, esmolol. So you can also use a continuous infusion of labetalol, esmolol. Now the question is, how will you reduce the blood pressure? How will you titrate the blood pressure? Now OPGI textbook clearly says in the first 8 hours reduce blood pressure by 25%. In the first hour 10%. So this is the MCQ straight away taken from OPGI textbook. 10% in the first hour, and then will gradually reduce over the next 24 to 36 hours. So then we'll gradually reduce the blood pressure over the next 24 to 36 hours. Okay, cool. So if I take you back to this question, in hypertensive emergency, how do you reduce the blood pressure? So clearly the answer of this question is 10% in the first hour. Okay, 10% in the first hour. Okay, so it has to be slow reduction. So remember, this was a pediatrics question. So OPGI clearly says 10% in the first hour, 25% in the next 8 hours. Okay, okay, cool. Let's take you to the next question, and what we'll do is we will make it interactive. Now I want all of you to tell me what is the cutoff of respiratory rate in a 2-year-old child. I will also tell you what about a newborn, what about other age groups. But what do you think, guys? This question came in UPSC this year. What should be the cutoff for a 2-year-old child? So first of all, let me show you newborn. So the IMNCI guidelines, you remember the IMNCI guidelines, they typically talk about the cutoff. Let us talk about first less than 2 months. And I want to highlight two things. IMNCI guideline for children less than 2 months says, number one, in children between 7 days to 59 days, in babies between 7 days and 59 days, pneumonia is 60 breaths or more. Okay, so what is pneumonia? Infants 7 to 59 days old, respiratory rate 60 or more. Now look at this. In the first 7 days क्या होगा? Now if you see here, remember in the first 7 days fast breathing की definition अलग है. Now in first 7 days this is not pneumonia, इसी को बोलेंगे serious infection. So remember, they will ask you, UPSC guys will again ask you that 60 or more, 7 to 59 days, so 7 to 2 months is pneumonia. However, in the first 7 days, this is called serious bacterial infection or very severe disease. So remember, in the first 7 days of life, the same respiratory rate को बोलेंगे serious bacterial infection or very severe disease. Okay, तो ये तो बात हुई पहले 2 महीने के बच्चे की. Let us talk about children more than 2 months. Okay, let us talk about children more than 2 months. What is pneumonia in children more than 2 months according to the IMNCI guidelines? So remember, according to the IMNCI guideline, chest indrawing is pneumonia, number one. चाहे सांस तेज चल रही हो ना चल रही हो, chest indrawing is pneumonia. Number one. Number two, fast breathing. Now this brings me to your question. So remember, 2 to 12 months of life, respiratory rate 50 or more is pneumonia. 12 to 60 months of life, respiratory rate 40. 60, 50, 40 is pneumonia. Okay. So 2 to 12 months 50 or more, 12 to 60 months. So our patient was 2-year-old. So answer was 40 or more. And the drug of choice for pneumonia is amoxicillin according to WHO for 5 days. Okay. Now if this patient has a danger sign, by which I mean, suppose he has lethargy, he has convulsions, vomiting, it is a danger sign. It is severe pneumonia or very severe disease. Okay. Now stridor in a calm child. Now remember, pulse oximetry is part of the INICET guideline. Remember, so if the saturation is less than 90%, it is severe pneumonia or very severe disease, for which we give intramuscular MP Angenta and refer urgently. Remember that accord for the UPSC CMS, your OPGHI and your INICET guidelines, basic health programs are very important. So let's go back to this question. So the answer of this question for a 2-year-old, the answer was definitely 40 or more. Okay, let's go further to the next question. And the next question I have is this: what do you do for hyperkalemia? Okay, which of the following agent will you use for a patient who has hyperkalemia? And your options are calcium gluconate, insulin with glucose, ipratropine bromide, sodium bicarbonate. Huh? What do you think? So of course, remember, for hyperkalemia, number one, if a patient has ECG changes, you will always give calcium. There is no doubt about it. So if a patient has ECG changes, always give calcium, because calcium is a cardioprotective agent. It stabilizes the cardiac membrane potential. So for severe hyperkalemia, we give insulin with dextrose, because all of you know insulin causes the transcellular shift. From the extracellular potassium, it shifts it to the intracellular. Of course, you know what is hyperkalemia. Potassium is more outside the cell. So it shifts it causes a shift, transcellular shift. Similarly, we give nebulized salbutamol for the transcellular shift. Okay, salbutamol is very important. So not ipratropine bromide, we give salbutamol. And remember, the dose of salbutamol for nebulization is much less. However, the dose for hyperkalemia is more. You should know this. The dose of salbutamol for hyperkalemia is more. Number one. Number two, of course, if this patient has acidosis, we will give sodium bicarbonate. So the answer becomes 1, 2, and 4. So this becomes your answer: 1, 2, and 4. Okay. Now, in fact, the next question also was the same. Nebulized salbutamol is used in which electrolyte abnormality? In fact, both of these questions were next to each other. So these two questions were on management of hyperkalemia. So guys, in the chat box, I can see a lot of you in the chat box. So can you tell me, nebulized salbutamol will be used in management of which electrolyte abnormality? Of course, we just discussed for hyperkalemia. So salbutamol is used for hyperkalemia. For hyponatremia, remember, we look at the patient's fluid status. If the patient's fluid status is more, so remember, for hyponatremia, if any patient has symptoms we will give him a bolus of 3% saline. Okay, 3% saline. Okay, otherwise if he's like a SIAD patient, we will restrict the fluids. Okay, for hypomagnesemia, of course, we will supplement magnesium. For hypernatremia, again, if a patient, you need to look at his fluid balance. Mostly we give them a fluid like N/2, almost 1.5 times the maintenance. So we give them increase N/2 fluid more than 1.5 times the maintenance, and we do slow correction of sodium to avoid causing central pontine myelolysis. So these patients should not get CPM. So if there is a rapid fall of sodium, they can get central pontine myelolysis. Okay. Okay. So the next question I have, which came in this UPSC CMS, is on burns. It was about how to manage fluid therapy in burns. What do you think is the answer of this question? The options are: Parkland formula estimates the fluid to be given over 24 hours. It tells the volume of the fluid. So if you look at the OP current edition, it has a beautiful algorithm. And let me take you to this algorithm first, okay? Then we will come back to the question. So how do you manage burns? So remember, the Parkland formula, if you look at the Parkland formula, it is 4 ml per kg multiplied by percentage of burns, and usually we give ringer lactate. Okay, 4 ml per kg multiplied by percentage of burns, and you also have to give maintenance fluid in the form of 5% dextrose and RL. So it is 5% dextrose in ringer lactate. Now in the initial 24 hours, you give half of the resuscitation volume in the first 8 hours and the rest in the, so we have calculated this. Out of this, half we give in 8 hours, rest in 16 hours. Okay, half in 8 hours, rest in 16 hours. Remember. So after the first 24 hours, you will give maintenance plus hourly ongoing losses calculated as 25 plus percentage of burns, okay, into body surface area. So this is later on. So let me take you back to the question which we showed you. Let me take you back to the question which I asked you. See, this is OP textbook. Okay, Dr. Nimra, in the chat box, this is the current edition of OP textbooks algorithm. The current issue is the 10th edition of OP. It is clearly given in this OP textbook. So let's look at what is true. Okay, so first statement is true, definitely. We have to give it over 24 hours. Even this also tells you the volume of is the 4 ml per kg multiplied by percentage of burns. Additional maintenance has to be also given. Now remember, half is to be given, not 6 hours. This is wrong. It has to be given over 8 hours and the rest over the next 16 hours. So this fourth statement is wrong. So the answer becomes 1, 2 and 3. Okay, 1, 2 and 3. Okay, so the last statement is wrong because the rest of the resuscitation fluid has to be given over 8 hours, half in 8 hours, rest in 16 hours. Okay, so the next two questions which came in this UPSC exam were on primary and secondary apnea. So these questions were on primary and secondary apnea. Let's talk about primary and secondary apnea. Now see, whenever a child, how do you determine a baby is breathing or not? So remember, before a baby goes into irreversible apnea, initially baby goes into primary apnea. So suppose you see a newborn in your labor room. So what will happen initially? After a rapid breathing, the baby goes into a time of primary apnea. At this time, he may respond to tactile stimulation. Listen to me carefully. At this time, he may respond to tactile stimulation. Okay. After this, he goes into some intermittent gas and then goes into secondary apnea. Okay, then he goes into secondary apnea. Okay. Okay, चीज बताओ तुम क्या कहना चाह रहे हो? हाँ? So cheese, follow OP Ghai textbook for the UPSC exam. Clearly talks about the OP Ghai textbook, and the answer was as I told you. Okay, cheese. I hope you will say cheese now. Okay. So primary apnea, remember two things. It responds to tactile stimulation. Secondary apnea does not respond to tactile stimulation. We should start positive pressure ventilation. So remember, any patient you see in the labor room, any patient you see in the labor room who is in apnea, you should think of secondary apnea. Okay, so let's first take you to this question number 1, and let's look at what is primary apnea. Of course, we know primary apnea responds to tactile stimulation. Okay. Now you cannot clinically, देखो clinically आप नहीं बता सकते कि बच्चा प्राइमरी में है सेकेंडरी में है. देखो यह देखिए ध्यान से, I'll show you this. यह ध्यान से देखिए. In primary apnea, heart rate is reducing. Okay, BP is fine. But in secondary apnea again ये दोनों ही कम हो गए, BP भी कम हो गया, heart rate भी कम हो गया. ठीक है. So remember, in labor room, whenever a baby is in apnea, think of secondary apnea, start ventilation. Okay, so let's take you back to the question. Primary apnea mein heart rate is falling, BP is normal. Okay, so this was the first question. Of course, primary apnea responds to tactile stimulation, heart rate is falling, BP is normal, tone is decreasing now. Second option, and you are right. Okay, you are right. The second option. Okay. Okay. Now the next question was, if a baby does not respond to tactile stimulation, assume the baby is in secondary apnea and start mechanical ventilation. So remember, if a baby does not respond to tactile stimulation, assume the baby is in secondary apnea and start positive pressure ventilation. Okay, cool. Let's go further. Now the question is about some normal phenomena in newborns. In all of our classes, we discuss about normal phenomena in newborns. Now one of the normal phenomena is witch's milk. Witch's milk, by which I mean a baby may have, even a newborn may secrete some breast milk. So this is a photograph from the OP Ghai textbook showing that even some newborns may have some drops of milk like fluid. This is called the witch milk. Okay, this is normal. Even in boys this is normal. Okay, this is because of transplacental transmitted hormones. Which hormone? Estrogen. Okay, so remember, witch's milk is usually seen in term babies. Remember, it is usually seen in term babies, not in preterms. It is usually seen in term babies. It is because of transplacentally secreted estrogen, not progesterone. Okay, so it is not progesterone, it is estrogen. And remember, it is mostly seen in 6% of term babies also. So this is quite normal in term babies, boys or girls. This is normal. So we talked about witch's milk. Let's go further and let us talk about another. Maybe I'm sure this question must have being discussed by some other faculty also. So but still, what I'll do is I'll still talk about this question because we also discuss genetics in pediatrics. So when we talk about Down syndrome, remember, is mostly trisomy 21. Okay, so all of us know Downs is trisomy 21. 95% of Downs is trisomy 21. Okay. Now, what is the risk of recurrence of Down's syndrome? If baby is trisomy 21, and now we are talking about what will happen to the next baby. If mother is old, then 30 years, risk is, remember, age specific risk. So risk will be age specific. Okay, whether mother is a senior resident or mother is a professor, it depends on her age. So as the mother's age increases, the risk of having a baby being Down syndrome increases. Sometimes young mothers can also have trisomy, then the risk is 1%. So see, 95%, so we are talking about previous बच्चा क्या था और अगले बच्चे में we are talking about the risk of recurrence. Okay, now so see, 95% of Downs is trisomy 21, but what about 3 to 4% of Downs? It can be Robertsonian translocation also. So remember, 3 to 4% of Downs can be Robertsonian translocation. So basically a child got a translocation between two acrocentric chromosomes from one of the parent. तो यहां पे हम करवाएंगे पेरेंट्स का कैरियोटाइप. बच्चा गॉट दिस क्रोमोसोम फ्रॉम फादर और द मदर. सी, इन आवर रूटीन प्रैक्टिस हम पेरेंट्स का कैरियोटाइप नहीं करवाते. रूटीनली हम पेरेंट्स का कैरियोटाइप नहीं करवाते. ओके, हम कब करवाते हैं? जब बच्चा इज रॉबर्टसोनियन ट्रांसलोकेशन, बिकॉज the risk of translocation, the risk of recurrence is different. Okay, so if mother has a translocation of acrocentric chromosomes, remember ये सारे acrocentric है. 13, 14, 15 5 chromosomes acrocentric है body में. 13, 14, 15 group D, 21, 22 group G. So if mother has DG translocation 15%, father has this DG 13, 21, 14, 21, 15, 21, 5%. If mother has 21, 22 translocation, 10%. And this was the question in your exam. Any parent with 21, 22, 21, 21 translocation, remember the risk of recurrence is 100%. Very important for all of your exams. 100%. So if I take you back to the same question, risk of Downs is 100% if either parent is a carrier of 21-21 translocation. Okay, so if any of the parent is a carrier of 21-21 translocation, this was question number 109 in the paper UPSC. Good, let's go further. Now the next question was on genomic imprinting. So in all of my pediatrics classes, I always talk about genomic imprinting. So I know maybe some other faculty, maybe it will also come in your pathology class also. But let us talk about genomic imprinting. You should all know that there are 8 examples of genomic imprinting, very important for your exam. Whether it's UPSC, whether it is INICET, NEET PG, at least you should know 8 examples of genomic imprinting. 8 examples. Remember, 70% of Prader-Willi, 70% of Angelman, Temple syndrome, Wang syndrome, Temple, Wang, Seckel syndrome, a very rare syndrome called transient newborn में diabetes. Transient neonatal diabetes mellitus is also genomic imprinting. Okay, Beckwith-Wiedemann syndrome, And not to forget about a very rare syndrome called pseudo hypoparathyroid 1b. But they can still ask you someday pseudo hypoparathyroid 1b. Okay, so let's look at this question. So of course Angelman is genomic imprinting, Prader-Willi is genomic imprinting. Now remember, Williams and D. George are micro deletion syndromes. Okay, so answer hai yes, first option. But all of you remember, whether you are a NEET PG aspirant or a INICET aspirant or a UPSC aspirant, remember Williams is a micro deletion syndrome. Chromosome 7q, chromosome 7q microdeletion syndrome. Okay, D. George is also a microdeletion syndrome, 22q11 deletion. So we diagnose them by FISH. We diagnose these microdeletion syndromes by fluorescence in situ hybridization. Okay, now the next question is about breast milk. Which statement is true? I know maybe you must have been taught about this in your gynecology class, but I want to bring your attention to OPGHI textbook. OPGHI textbook के एक एक सेंटेंस से ये क्वेश्चंस लिए गए हैं. OPGHI में ध्यान से पढ़ो. लैक्टोज क्यों होता है ब्रेस्ट मिल्क में? Because lactose helps in the absorption of calcium and enhances the growth of good bacteria, lactobacillus. Okay, breast milk has low protein. It has taurine and cysteine, important for brain growth. Remember, breast milk has taurine and cysteine, important for brain growth. Okay, when we talk about PUFA, breast milk has polyunsaturated fatty acids. It has omega-3, so especially omega-2 and omega-6 fatty acids. Okay, so yahi sab questions hai. Lactose helps in calcium absorption. Breast milk has taurine and cysteine. It has omega-2 and omega-6 fatty acids. Okay, now the water content in breast milk. अब देखिए इस पे भी क्वेश्चन आ गया एग्जाम में. आई एम सॉरी अबाउट दिस, बट हाँ क्वेश्चन तो था. 88%. The water content of breast milk is 88%. Okay, so this baby does not need more water in the first 6 months of life. It has low solute load. Okay, let's look at the question now. So first statement is wrong. 88% of breast milk is water, not 75. I am sorry about this. Breast milk is rich in taurine and cysteine. We just showed you. Okay, so first two statements are wrong. Now breast milk is rich in omega-2 and omega-6. High lactose helps in absorption of calcium. Okay, so the answer is 3 and 4. Okay, I know maybe this is again a question straight away taken from OPGHI textbook. I know maybe in the gynae recall you may again see this. However, this was taken from OPGHI. Okay, word to word. Let's take you to the last question. The last question is about attachment. So again, OPGHI textbook has this photograph. The new textbook OPGHI is having beautiful photographs, and now this photograph talks about what is a good attachment. So all of you should know the 4 sentences. What is a good attachment? Number 1, baby's mouth is widely open. Number 1. Number 2, most of the nipple and the areola is in his mouth. Only the upper areola is visible. Can you see here? Only the upper areola is visible. Baby's chin is touching the breast. Lower lip is everted. अब देखो यहाँ नोज की कोई बात नहीं हो रही है. ओके, यहाँ नोज का कोई बात नहीं है. 4 बातें हैं. फिर से बोलूंगा. माउथ वाइडली ओपन, nipple and areola in the mouth, only upper areola is visible, baby's chin touches the breast, lower lip is everted. So let's take, so nose की बात नहीं हो रही, okay, nose is not mentioned, so this statement is not written anywhere. So yes, mouth is open, chin touches the breast, lower lip is everted. So 2, 3, 4 is the answer of this question. Okay. Yes, if you are aiming for UPSC exam, straight away you will see all you need to go for is OPGI textbook and also the class notes. This is enough for you. You don't need to go for any hi-fi thing. Just class notes and OPGI will be enough for you. So that was all about pediatrics, which came in the UPSC this year. So if you want to take an advice from me, guys, I would say just your class notes, believe in your class notes, revise your notes, do regular CBTs, okay, if possible, you know, also look at the grand tests and just revise these topics. This will help you in your exam. Okay, don't go for new stuff every time. Whatever you are reading, just revise with a basic textbook in your hand and your notes in your hand. Back to Basics on DAMS is an excellent resource, and we have made all the Back to Basics videos topic wise. They will really help you guys. So if you have any doubts, feel free to tag me on Instagram or email me anytime. I respond to all the queries. Most